A warm welcome to all the viewers. This is the first video out of a series that we have planned primarily to provide point of care advice to our nurses and doctors caring for the critically ill in COVID-19 ICUs. The current video gives a short overview of the closed section apparatus and demonstrates how it's used in the ICU. First, let's see how an open section is performed. Here, the patient is disconnected from the ventilator at the ET tube. A catheter is inserted into the ET tube and then tracheal suction is performed. Disconnecting the patient from the ventilator and tracheal suction, which is an aerosol generating activity, exposes the patient's secretions to the external environment and healthcare providers, which poses an increased risk to the transmission of COVID-19. An inline suction catheter obviates the need to disconnect the patient from the ventilator. It thereby prevents the escape of aerosols and droplets into the environment, which is probably the most important reason why we are using an inline suction catheter in a case of suspected or proven COVID 19. It also prevents or reduces the sudden loss of PEEP due to disconnection. This is more pronounced in the case of an ARDS, where there is diffuse destruction of the alveoli, which are filled with fluid and need a positive and expiratory pressure to prevent getting collapsed. At least 30% of the COVID 19 patients who present in respiratory failure will have an ARDS phenotype. In the inset is a pig slum, which instantly de-recruits and collapses as the PEEP is removed by disconnecting from the ventilator. A similar phenomenon would occur in ARDS patients when they are suddenly removed from the ventilator and deprived of PEEP. Closed section apparatus is also likely to prevent ventilator associated pneumonia by preventing inadvertent introduction of organisms to the tracheobronchial tree. This is a 14 French inline suction catheter which would be suitable for ET tubes with internal diameters of 7 up to 8 millimeters. As a rule of thumb, 2 into ETT size is generally the correct size of the suction catheter that should be used. The closed suction apparatus has a T-piece with two ports, one of which attaches to the ET tube and the other to the ventilatory tubings. The suction catheter is held inside a transparent sheath through which the catheter depth markings are visible. At the distal end of the suction apparatus is a port to which the suction source via a tubing is connected. This blue lever, when pulled open, channels the suction pressure into the suction catheter. There is also a syringe port for the purpose of rinsing and cleaning the suction catheter after use. The ventilator tubing, along with the HME plus bacterial/viral filter, is attached to one end of the adapter. This assembly is kept ready prior to intubation so that as soon as the patient is intubated and the ET cuff inflated, the assembly is attached to the ET tube. If not visibly soiled, closed suction catheter can be used up to 72 hours. The day of change of the suction catheter can be marked on the T-piece with the help of these labels that come with the package. The closed suction apparatus shown in this video has a similar access point for attachment of ventilatory tubings on the other side as well, which would come handy when changing the position of the patient as well as the ventilatory tubings. This particular suction catheter also comes with a blue adapter which acts like a rotating swivel which could reduce the torque between the ET tube and the suction apparatus. Though this might increase the dead space in children, this may not be a big problem in adults. Now, we would demonstrate the entire procedure of tracheal suctioning. Before doing the procedure, make sure you have done proper hand hygiene with alcohol-based hand rub for at least 20 to 30 seconds. Within the COVID isolation wards and ICUs, this would mean that you have to perform hand hygiene with alcohol-based hand rub over the gloves as well as dispose the gloves between patients. The first step is to pre-oxygenate the patient with 100% oxygen. This step is necessary because even the inline suction catheter could cause a drop in PEEP and lead to deoxygenation. This can be performed by pressing the 100% oxygen button on the ventilator. After pre-oxygenation for 1 to 2 minutes, a suction tube attached to the wall suction or a suction machine is attached to the rear port on the inline suction catheter, taking care not to switch on the suction machine prior to attaching the tube. It should be made sure that such a compatible tube is present prior to the procedure. The suction apparatus is subsequently switched on. The knob at the end of the suction lever is turned so as to allow free movement. After making sure that the depth markings on the suction catheter are visible, advance the suction catheter by holding onto it with the overlying plastic sheath into the T-piece and subsequently into the ET tube. Advancement is done until the markings on the suction catheter correspond with the markings on the ET tube. At this point, the tip of the suction catheter would have just traversed the tip of the ET tube. Suction catheter should not be advanced any further so as to prevent any mucosal injury to the trachea. Now the blue lever is pulled, which initiates the suction, and while maintaining constant negative pressure at the lever, the suction catheter is pulled out of the ET tube into the plastic sheath over 5 to 10 seconds. The procedure can be repeated if the secretions are not completely cleared based on the clinical judgment. After the procedure is completed, the secretions inside the suction catheter can be rinsed and cleared by flushing saline through a 2 ml syringe attached to the syringe port. Suctioning is performed as saline is flushed until the suction catheter is free of secretions. Volumes as low as less than 0.5 ml are sufficient to fill the suction catheter. Care should be taken not to instill saline into the ET tube at this point. Post procedure, the suction apparatus or the central suction is switched off before attempting to remove the suction tube from the attached site. Trying to remove the suction tube prior to switching off the suction can inadvertently spray the secretions into the room, which may cause more harm. After finishing the procedure, hand hygiene is done according to WHO recommendations. Kindly note that in the absence of a closed suction apparatus, it would be advisable to use a muscle relaxant prior to open suctioning, as this to decrease the chance of the patient coughing up and spreading aerosols into the room. However, the decision to use muscle relaxants should be made only in consultation with the treating medical team to make sure that its use is not inappropriate at that particular point of time in the illness. That concludes our current video. Thanks everyone for watching. We will be back soon with more videos.